Hello everyone. This is the recap of our Hemostasis week, 15th of February 2025. For those who are not the members and still planning for the FRC Path exam, this attempt or next attempt. The first question was about a young female with melena and having a very low von Willebrand antigen and activity. So the diagnosis was type 3 von Willebrand according to the levels provided, and we asked about uh, treatment support in the UK, which can be tranexamic acid for mild diseases, and for moderate to severe bleed, it can be factor concentrate, either single agent or combination agent, depending upon the levels. This patient has both low factor 8 and 1 milligram antigen, so it need combination agent. There is no room for DDVP here because patient has no 1 milligram stores, so we should avoid using DDVP in type 3 1 milligram disease. This patient acute treatment needs resuscitation, which include IV fluid, blood transfusion, but the most important thing is the concentrate provision to this patient. And the concentrate in this patient that we need to provide is Vocento, which contains both factor 8 and the von Willebrand. For example, if this was a known patient of type 3 on prophylaxis, and now the patient has presented with a bleed, I would have given him um, I would have given him this patient no 7 first, because maybe this patient has developed inhibitor for the one milligram. That's why she has bled. Once the inhibitor uh, is confirmed that it is not developed, then I would have gone for the factor concentrates. So inhibitor does develop in one milligram, but it is especially in type 3 because they need regular prophylaxis as well. After addressing the acute bleed in von Willebrand type 3 von Willebrand patient, you can then take history, investigations, uh, discussion with the patient, treatment options, and follow-up. But because this patient is a new patient, this patient will need registration with your tertiary hospital and the National Hemophilia Registry, bleeding disorder card, HemeTrack app, and education about future planning like pregnancy and um, um, procedures, etc. And important thing is the um, genetic test to confirm the diagnosis. You need to contact the GP as well if this patient has other siblings, whether they have been diagnosed with any type of vulnerable disease or any bleeding disorder or not. Then the next important thing is the prophylaxis. This patient will go home uh, on prophylaxis because it is a type 3 von Willebrand disease. She does not have any von Willebrand store. She can bleed again easily, either spontaneously or secondary to trauma. So you need to give this patient some prophylaxis as well. So do not miss the fact that whether this patient needs single factor agent or concentrate, and think about DDVP whether it is contraindicated or not, because DDVP cannot be used in all cases of von Willebrand disease. And secondly, genetic testing. You need to do consent for genetic testing, and prophylaxis, which is only used in type 3. I would advise to go to your hemostasis department and ask them about HemeTrack app. The CNS, hemophilia or hemostasis CNS, will tell you what is HemeTrack app. Ask them to show you the bleeding disorder card, and once you see the bleeding disorder card, you will not forget in the exam to mention it. Ask them to show you the consent form for genetic testing of bleeding disorder. It is very important that you should know about that and read it, what is mentioned in it. Because when we consent the patient for genetic testing, we mention to them that um, we we are doing test for confirmation of von Willebrand disease, but there may be some other genetic problems that may or may not have implication on your life. And see the leaflet of a bleeding disorder genetic test. The second question was about antiphospholipid syndrome. The patient has a very strong positive anticardiolipin and beta 2 glycoprotein antibodies, and has a DVT as well. So this patient had DVT further down in the question. I mean, this patient has a DVT 6 months ago, and now the orthopedic team are planning arthroscopy. Arthroscopy is a low bleeding risk procedure, but still, for any procedure, you have to apply PBM measures as well to prevent prevent blood loss in the patient. So many candidates mentioned patient blood management, and uh, that was a good point to mention in the essay. Now the question was regarding peri-operative anticoagulation. The guideline have mentioned BSH guideline, few indication in which you need to do um, the bridging, pre-op bridging in case of warfarin, which are the VTE in the last 3 months, or VTE or anticoagulation, uh, recent TIA or stroke, mechanical heart valve. So I had shown the picture of the indications in the part one group as well. You can see that in the guideline as well. It is 2016 guideline, I think. If the patient does not fall into this category, you are not required to give uh, pre-op bridging in case of warfarin. Stop warfarin 5 days before, and check INR day -1. If it is less than the required anesthetic target, which may be less than 1.5 in some hospital, less than 1.4 in another hospital. If it is above, then give vitamin K, INR will come down. And then post-op, start low molecular weight heparin after 6 to 8 hours, because patient is having surgery, bedbound, and antiphospholipid syndrome, so it's a high risk procedure, high thrombotic risk procedure. So give him prophylactic dose after 6 to 8 hours, and then from day +1 start bridging with low molecular weight heparin. Follow your trust guidelines about the warfarin bridging, and you will be able to answer the question in the exam as well. Your trust might have um, guidelines regarding duos, guidelines regarding the regarding the lumic heparin as well in table form. If not, the BSH has the table mentioned for perioperative management of duos, etc. in the BSH guideline. It was updated in 2022, I think. In managing in arranging treatment for this patient, because it was diagnosed as an antiphospholipid, most likely because antibodies are very strong. In the treatment options, the first option is warfarin, but before that you have to do a pregnancy test, because this patient was a young female of childbearing age potential. Giving a young female in a scenario means that you have to do a pregnancy test, or this question is related to pregnancy in one way or other way. So do not forget pregnancy test in starting anticoagulation, because it has implication uh, on the pregnancy planning as well. If you are starting duocolomicron with heparin, mention a reason. This is the patient preferred choice. or patient has allergic reaction or do not wish to have warfarin, because if we are suspecting antiphospholipid syndrome, then warfarin should be the first choice. And this patient has DVT and very strong antibodies. So this is likely antiphospholipid, but we need to confirm that by repeat testing after 12 weeks. Thank you.